Um, so elder law is basically a holistic area of law. When I took the certification exam, it was about 17 different areas. So whether it's housing or care or um, Medicaid, Medicare, public benefits, probate, documents, all of that stuff. But the goal between with elder law is to, find the appropriate type of care, coordinate that care, pull public and private resources, and then working to make sure that people get quality care. So the reason I mentioned the elder law is that it's, Medicare is a part of it. And we just like, I want to make sure that we're, covering kind of all the different things. So long-term care, I don't have to tell most of you, I'm sure you're in the business, but most people community-wise think just nursing home. They don't really think about assisted living or adult day services or all of these other things. So they don't know about hospice, respite, even dialysis services and which places have dialysis, which ones do not. So it's really important to have we try to have the goal of educating our clients. So all of that is covered. Everything that helps with activities of daily living, bathing, transferring, eating, dressing, toileting, and I got transferring twice, but yeah, so you know the deal. So Ohio has about 5%. This was in 2005, so I'm sure it's 10 times more now. 5% of all people age 65 and older reside in a nursing home. Probably that's a bit less just because of all the different options. And obviously, we're all in sort of in a business where by 2050, we're going to have 17 million plus people, all those people needing services of some kind or another. So this is the elder care continuum where we all kind of work in this paradigm. But the first line here is like the functional limitations line. So we go from no functional limitations to limited function to even, needing a walker, a, jazzy thing, or, eventually wheelchair, bedridden, that kind of thing. So as people move along this line, we also have to be looking at where are they? What is the home sweet home line, the home with assistance? And then going all the way to nursing home and then I gotta like rest in peace. The cost of care obviously goes up, and then we've got to put all of the public benefits resources into the mix. So within the chronic care model here, you've got the community and the health system, which is part of the community. You've got resources and policies, but then the health system is supposed to have better clinical information system, decision support, delivery system design, and self-management support. And that's supposed to lead to productive interactions between a prepared, proactive practice team, which many of you are a part of, and an informed, activated patient. The problem is that there's very seldom, well, I won't say seldom, but the informed, activated patient is often lacking, especially if you have a surrogate decision maker. So we like to make sure that we're bringing the informed, activated patient to the healthcare system. So how we would like to age is we want to go from independent and healthy to rest in peace. You can ask my dad about this. This is like how he thinks it's going to go. More likely than not, we go from the hospital to the nursing home to back and forth until we pass. And then if we age in place with proper planning, we move along that top functional limitations line, and then on the home sweet home line, where we've got IADLs moving, instrumental activities of daily living moving, and we've got ADLs, retirement facility, all of those things. So ideally, if they're moving along this top line, they also are moving along the bottom. But what happens when they don't is that we have what's called a zone of danger. So that's just one thing to think about. And a lot of times people don't know the public benefits that they are eligible for to allow them to move along that line or to help them at home. All right, so cost of care is going up, quality of life's going down. So we're trying to help with all of that. So long-term care, you're talking now $30 to $50 per hour for home health care. Assisted living is anywhere from $5,000 to $9,000, and nursing homes can be anywhere from $365 a day to $500 per day. So who pays for that? Medicare, Medicare supplements, Medicare Advantage plans, Medicaid, private pay, and long-term care insurance. Most of it is private pay. A lot of clients still call me and say, well, I don't want to go into a Medicaid facility. And I'm like, well, wait a minute. Every Medicare facility is a Medicaid facility for the most part. So I try to explain to people, like, you're not going to be in a dark and dingy wing where there's I mean, every bed, nobody knows who's on Medicaid, who's not, other than probably the billing person. So Medicaid, the difference, and again, this is like my law students. I'm like, you got to know the difference between these two. So Medicaid is for all people, regardless of age. It's eligibility based on financial reasons. It's skilled or unskilled nursing home care. And it's a joint state and federal program. So the money comes from the federal into the state, and our Department of Job and Family Services administers it. Then Medicare, on the other hand, is for 65 and older or permanently disabled of any age for 2 years. It only covers skilled care. And then if you're in the hospital, you have co-insurance anywhere from $419 a day to $838 a day. That, of course, changes for inflation. So we're going to have, I think, a 2.5% increase next year. And then the skilled rehab. So once you're in, Medicare covers about days 1 through 20 in full, and then days 21 through 100, if you can get all of those days, with that co-insurance of $209.50. Those are all subject to a deductible of $16.76 um, per episode, basically. So that's how that works. Now the supplement will cover the other parts of that. So that 209 can be covered by your Medicare supplement. Same thing with the co-insurance, same thing with the deductible. So Medicare has 4 different types, basically. So you've got Part A, which is the hospitals, Part B, which is doctors and other ancillary services, Part C, which is not really Part C, but it's the Medicare Advantage plan, and then there's the drug benefit. And then you have the supplemental policies, which, like it says, supplements what is covered by Part A, B, C, and D. So Part A is hospitalization, short-term nursing home, and some home health, like only basically skilled. And it seems like they're covering a little bit more, but it's not enough for somebody to be like, I'm going to stay home and, live here and have 24-hour care. And then Part B is physician fees, co-pays, specialists, that kind of thing. And then prescriptions for Part D. And there have been some changes to that. And then Advantage plans, basically, Medicare said, we'll let you kind of like waive out of the traditional Medicare. And then these Advantage plans, and there were like maybe 40 or 50 of them in Ohio alone that offered people that they could get, well, so it would kind of wrap in A and B, and you wouldn't have, and the supplemental plans. So the Advantage plans were always attractive because you could get your silver sneakers, you could get your, what do you call it? You can get some home health, you can get other things with it. The problem is now we've got, they're cutting a lot of Medicare Advantage plans, particularly in the state of Ohio. And it was supposed to save Medicare money. I'm not so sure that it accomplished that. But about 50% of people are on those Advantage plans. All right, so traditional Medicare covers half of older Americans, but the rest have those Advantage plans. So that's a lot. I mean, because I don't think Advantage plans came out until, quite a bit, not too far ago. So the fact that we've had people who are they go to those Advantage plans is pretty significant. So again, eligibility is anyone who's over 65 is covered or who's eligible for Social Security. They're financed through a 2.9% payroll tax. So all of us probably on this Zoom are basically funding the Medicare coverage. It's half paid by the employee and half paid by the employer. There's an additional 0.9% tax on people who make over $200,000 who are unmarried, and $250,000 if you're married, and obviously $125,000 if they're married filing separately. You don't need to collect Social Security, but you do have to have you should do your Part A since there's no incentive to postpone that. In fact, we have another client where, we're starting to see people who are on the public employment or they're on their spouse is younger and they're still working, where, they don't have the Part B, and it's a big problem for, Medicaid and all of that. So,
And
sorry.
Rachel, I'll just interject that as a reminder, with dialysis patients, for home dialysis, they're automatically eligible the day they start their trainings, regardless of their age. And for in-center dialysis patients, the moment that I think it's 3 months after they start dialysis, they're eligible for Medicare. So
Okay.
a little bit different from the general population.
Thank you for sharing that. Because again, every person, it's like we want to say there's like a cookie cutter answer for anything with regards to public benefits, but it's really important to know, like, well, what do you have? What medications are you on? What are you doing? Like, do you have, I mean, there's just so many things. And so knowing exactly how that's going to get paid for, it's important to talk to, whichever, like doctor, agency, dialysis center, like what is going to work for each person. So let's see. Spouses, widows, and widowers who are 65 do qualify. A divorced spouse who is not remarried can qualify on a divorced spouse's record. So you got to be married 10 years, but you can get Medicare on the other person. You can have state and local employees who were hired before um, 331.84 and liable for that 2.9% tax. Also disabled for 24 months. I have a lot of clients where they have not maybe gotten you know, they aren't getting their Social Security, or they're not getting their full Social Security, and they are really disabled. I say go for the disabled, because then you can get your full Social Security amount. And if you're not 65, you can get Medicare after 24 months. So it's very helpful if they apply for that. Voluntary employees, enrollees, $518 a month for 2025, but they also have to take the Part B also. All right, and then Part B eligibility, it's paid through premiums and general taxes. So 25-75% split. It's in 2025, it's $185. It's going to go up, I'm sure of it, in 2026. Higher premiums for higher adjusted gross income. So if you are, and that includes if you take out money from your IRA, that can end up putting you over that gross income amount, or put you into that higher gross income amount. If you enroll in Part B later than when you roll in Part A, premiums will be permanently increased. Again, we're trying to figure out a client who's on the spouses. I don't think they're going to have a penalty, but at the same time, we got to figure out, you go off the spouse's insurance and onto Part B. So it's just a matter of learning all of that a little bit as we go, just to know, like, we have to run it both ways. Penalty does not apply to employer group plan enrollees. So again, our client who's on her husband's insurance will not have a penalty, but we also have to figure out, is it better to go off that? Because once you go off, you're probably not going back on.
Or whether they cover it, right?
Yeah,
The
or
insurance will cover what Medicare would typically cover for her care at a nursing facility.
correct. So yeah. All right. So Part A, again, you got this deductible. You've got the days 60 through 90. I haven't seen well, they have to be pretty catastrophically disabled, but they might get that, into that 419. I don't generally see someone again up in this 150 today cost, and probably trying to move you out well before then. Skilled rehab, again, days 0 through 20 are covered in full, and 21 through 100 have that copay. Again, coverage under Part A, hospital, SNF, hospice, whatever is reasonably necessary, no unproven or experimental treatment, and we should say, like, also the dialysis, semi-private rooms unless the private is medically necessary. And hopefully more nursing homes are just going to a private room. But all right, so limits are based on days in the facility. It begins with admission to a facility and ends when a person is out of the hospital for 60 consecutive days, or at least off services in the skilled rehab. So again, just people think, oh, let's just get more Medicare. And I'm like, listen, you're out of your, you don't have your 60 days out. So it's really important that we have, um, you get your spell of service, and then you've got to be healthy, or at least not using Medicare services for 60 days to start another one. Um, let's see here. All right. So this is just an article, and let me see if I can open it. Nope. Okay. So hopefully you guys can get the slides, but we have so many issues with people who are popping back into the hospital. And of course, we were supposed to have, law changes that would allow people to go, that hospitals would not have, they'd have them on that same stay, or they would have to pay when someone went back in. But it's just, I'm not so sure that that's happening realistically, but we'll see. All right, so in a hospitalization, they pay everything during the first 60 days after the deductible. And again, that's 1676. All other costs, including meals, ICU, CCU, pharmaceuticals used in the hospital, labs, medical supplies, PTOT, all of those things are covered as part of that 1676. And then there's a 190-day limit for inpatient psychiatric care. I'd like to see anybody get 190 days anymore. I don't know. Let's see. Part A, again, no, I covered that. Hold on. So the SNF, the skilled nursing facility, has to be Medicare approved. Almost all of them that are taking patients are doing that, I think. Admission must follow a hospital stay within 30 days. So there's always that 3-day rule. So again, if the hospital or the doctor participates in an accountable care organization, you don't have to have the 3 days. That's usually in the Advantage plans. And then people say, well, I went home and it didn't go well. Well, then you can go back in, or you can go into a rehab and still get a new stay, a new Medicare stay. The patient has to need skilled services, so it can't just be custodial or dementia care, for instance. So what is skilled? It's ordered by a physician, requires the skills of a technical or professional personnel under the supervision of that person. Daily services at a skilled level, not twice a week. So again, you can't be like, I don't feel like going to therapy today. I'm going to go in 3 days. It's got to be every single day that you're doing the PTOT services. A lot of times clients just say no because they're tired, and it's like I'm telling the families, like, no, go there and kind of make them get up and make them do a little bit more than they did yesterday, just to keep it keep them skilled for longer. And again, covers all costs for 20 days and 80 more at the 209. Home care, they'll cover for people who are unable to leave their homes, except with assistance from devices like walker, wheelchair. You have to have a written plan of care. The home care agency must be Medicare certified, and it covers services such as PT, OT, speech therapy, medical supplies, durable medical equipment, all of that stuff. So again, it's got to be skilled. So I'm not sure how many times people are able to use this. I think it's it's going to depend probably on the Advantage plan, but I would say it's not likely to be 28 hours per week unless they have a severe skilled need like infusions or like bed sores or things like that. Part A only covers that if it's a 3-day stay. And then 100 visits within a home health spell of illness. So again, homebound, kind of covered that. So I got a little cold, everybody. Hospice, if you have a life expectancy of less than 6 months to live, you have pain relief, you need pain relief and symptom control. It will pay for doctors, nursing services, home health aides, homemaker services, medical supplies, drugs, other custodial care items. Typically, they're provided by a hospice company. There's obviously nonprofits too. You get 2 90-day periods and then another one at 60 days if needed. If you change your mind, you have your days left of your 90-day. Oh, the days that you have left on your 90 days are forfeited. So it's really important for people to kind of stay in there. But hospice, I think, is a good benefit to just keeping people comfortable and having pain relief. And then if they're, if there's nothing that they can't be treated, hospice tends to be a good option for some people. I'm not saying that, but Medicare pays hospice a really good amount of money, just saying. So, and that's why I see such a proliferation of hospice companies. But it's definitely good to they're not all the same. So it's important to know, what the difference between hospice companies are, or the nonprofits. There are places that have in-home hospice, or like facility-based hospice, either in a nursing home or they have their own hospice house, which can be really nice, but they only do that at the very end of life. All right, let's see here. All right, so Part B, physician charges, specialists, tests performed in a doctor's office, second opinions, some home health services, preventative care, end-of-life planning, and annual wellness visits are all covered by Part B. Sometimes you can get Part B coverage for PT and OT at home. So you got your Part A, but then you can actually tack on another Part B, which is kind of nice too. I know companies that do that. All these screenings for colorectal cancer, pap smears, pelvic exam, blood transfusion. The therapy cap is $24.10, but the deductible is only $257. Yeah, so that can be really a benefit to people. So here, as really small, I know, but this is the higher premiums for if you make too much money. So if you've got greater than $200,000 and less than $500,000, your 185 suddenly becomes 454. So this doesn't have, you may have people who are just genuinely wealthy and have a high income, but it's often times when they had to pull money from their IRA, and this puts them over the amount. So that can be very stressful on clients.
Rachel, I have a question here that was asking with palliative care, is that covered through Medicare as well as opposed to hospice?
Yes, palliative is definitely covered, and palliative and hospice a lot of times go together, and you can have a hospice company that offers the palliative care services as well. So palliative, the difference between palliative and hospice, I'm going to butcher this probably, but is basically that, you can have more services that extend your life. Whereas in hospice, you really have to cut things that are, extending your life rather than bringing you comfort. So they'll kind of balance those things out with the hospice versus palliative care. But you can certainly, if you're not ready for hospice, you can certainly do the palliative, and Medicare will cover that. Good question though. All right, so Medicare Advantage, and this is probably changing as I'm sitting here. It's a private insurance overseen by Medicare. It can offer extras such as I said, vision, dental, and gym. It can use as a specific network. I tell people here in Cleveland, it's not the worst thing in the world. You're either in UH or you're in, or Cleveland Clinic, maybe Metro, but so if your network is probably going to be fine, but if you're in Kansas or something, your network may not be able to support you. It changes annually. So everybody, this is open enrollment now. You can change it, right now and then try a different plan because that one switched to the formulary for the drugs or whatever. So it's important to know that clients should look at it every single year. Also, you can open that enrollment for any of these supplements or this if you move into a nursing home or you apply for or you get Medicaid. You can always open that enrollment period as well. So you have to be entitled to Part A and have Part B to qualify. And again, it includes the prescription. So that's a nice, it's all inclusive, which is why I think half of the seniors out there are enrolled in it. In 2026, again, I put all these in here. But definitely you can talk about, you can look at these on Forbes.com and see how many Advantage plans there are, all of that. So again, 32.8 million people are on the Advantage plan. It's 54% of the Medicare population, and it's $462 billion in spending. So yeah, I don't know why I can't open it. Oh, I don't know if you can see that. But anyway, take a look at those things because they're like, it's just interesting to see how many people are enrolled in Medicare, how many people, you know, um, what states it's popular in, all of that. So definitely you guys can take a look at the slides and link through here.
Rachel, do you have any like suggestions where if people, like mostly social workers are on this call today, where social workers can recommend that like renal patients can go to learn about like the different advantage plans and, what is covered for renal patients under these advantage plans?
Oh, that's a tough one. I mean, we work with an advisor that like I have found to be really helpful, and there are other ones, but I also find that there's a lot of people who sell these insurance plans who are just like it's just the latest thing to sell. Like I don't want to sound like jaded and whatever, but I think it's important to have an advisor that really knows the business and that knows the ins and outs of all of that. So I'm not sure. Like I know who I know, but I mean, I think Medicare.gov is good. I know that I use Medicare advocacy.org is another one to kind of see about like different rights that you have under Medicare. Um,
And the different coverages, right?
yeah, I mean,
Cause each advantage plan will cover these certain things and maybe not that certain thing.
yeah, and I think Medicare.gov can be pretty helpful about it.
Yep.
So, but I would say if people have an advisor, they could talk to their financial planner to ask them for a referral to, I don't know. I got to think about that. I'm going to get back to you. I can definitely email that and see like, where do you find the good people? I just know them because I've shared space with them in my office, but I don't love like the, health markets and things like that. Um, but yeah, I think everybody should have their advisor. But I'll double check of like where to find the good ones, and I'll shoot you an email to send out to everybody if that's okay.
And then I had someone post something that says Shine Programs, I guess is a organization that has uh some resources that are available as well.
Is that SHINE?
NE.
Okay.
Oh, and someone else
Oh,
said the SHIP program,
oh, the
the
SCHIP.
state health insurance program. So it seems like those are also some good resources that are
Okay,
available.
that sounds great. I mean, listen, there's like I said, I've known like people that do this, but it's got to be somebody that you know and trust. And it's because you could just be in like whatever pays them the most, and that's not necessarily the best thing. You need to have it so that it's what is going to give the person the best, coverage. And especially when you get into things where they do have chronic conditions, we've got to just make sure that we're, providing, getting good people for that so that we're not I always believe in like measure twice and cut once. I mean, and this is one of those things like don't sign up for something. And especially if you're signing up from Medicare, traditional Medicare to an Advantage plan, you may not be able to get back to Medicare because of,
Correct.
yeah, because of underwriting. So it's one of the few things, right? We got away where we don't have underwriting on most health insurance anymore, but not for Medicare when you're coming back to Medicare, and then you're stuck on your Advantage plan, or you can move to another Advantage plan. So this is like, it definitely gets very tricky in this area. But that's good to know about those other resources. Another really small rating thing, but Medicare Advantage, like these are all the chronic illness benefits. So this is great. Just like I said with that graphic about the informed activated patient, we do a pretty good job in this country of making sure that if you have a heart attack, you get, rushed to the hospital, you're good. But when we have chronic illnesses like kidney disease, like, other things, even cognitive stuff, we don't manage chronic illnesses well. I don't know if this is going to work as well as they think, but one of the key features is the chronic special needs plans, which are tailored for individuals with specific chronic conditions. So that's kind of nice. Zero copay, financial credits for purchasing over the counter products, credits for purchasing healthy food. Um, yeah, so it just requires you to be certified as a qualified chronic condition. Yeah, and then there's going to be enhanced care coordination for dually eligible individuals, Medicare, Medicaid. So this is promising. Medicare Advantage plans have been giving the credit cards for over-the-counter products. I've had one client where she got the food benefits and it was just $24 and it made her life, like she was so happy. So so we can definitely have this is hopefully going to be a good program. All right, so here's yeah, so oh, see, I had resources for this, Jennifer. I'm just glad to say it. But yeah, so which one should I buy? Original Medicare versus Advantage. So these are all like some websites to go to. Let me see if I can share this. Can you guys see that?
Yes.
Okay. So you've got like what the difference between the HMO, PPO, the SNP, the Medicare savings accounts, and you can,
You know
providers.
what? We're seeing the map of the US. I think
Oh, okay. Well, that's okay. All right, hold on. So let me just put that back over there. How about that now?
yes, we can see
Okay.
that now.
So yeah, so you've got like, the types of Medicare Advantage plans. Um, let's see here. Why is this not? Uh-oh, hold on.
So we could see a chart. What?
All right, hold on. Okay, wait. Let me go back to doing this thing up here so that everybody can see. Oh, no. Hold on. I gotta get back to my slide. Anyway, again, you'll have these Advantage plan options here to take a look at some of these. But this thing is interesting in terms of the Medicare Advantage enrollment is falling for 2026. So that'll be really interesting to see if, without like, what does that mean for the entire business? But I do believe that a bunch of these different companies are just getting out of the business altogether. All right, part D. I tell you, it's like 40 slides just to cover the basics. It's a lot. All right, so covers the prescription drugs. This has been insane with the like changes over time with the donut hole. But now we have so every company is different. There's 40 plus options in Ohio, and you've got to the clients have to look at the formulary of what are they on, which drugs, so that they can be on the right plan, so that they're not covered on something. There's a deductible of $590 per year. And then the client after that, I'm not sure exactly how this is going to all work, but 2,100 is the max out of pocket. It used to be like unlimited, and then 2,500 over that amount. So that 2,100 is a new number for 2025. So that's going to be beneficial to people, that they're not going to go broke trying to pay for their Medicare or their prescription drug coverage. Certain drugs are not coverable. Over-the-counter drugs, weight loss drugs, cough and cold preparations, fertility drugs. Not too many people in Medicare on the fertility drugs, but maybe somebody younger. Erectile dysfunction, cosmetic and hair growth drugs. Okay, so yeah. Drugs purchased in another country. I've had clients where they are able to get their drugs in another country, but they can't use their Medicare. So it has to be much cheaper than whatever they were going to get here. Vitamins and minerals, except niacin. And yeah, so then part A and B, if it's covered under that, won't be covered under D. Makes sense. So low income assistance, you get assistance on the part D if your resources are under 17,600, 35,130 if you are a married couple. Income, it has to be under 1956 or under 3,048 as a married couple. And then you can get the special help, and you have a lower coinsurance. So that can be helpful. So now there's a $35 limit on insulin. The catastrophic coverage for the drugs is the 5% is gone as of 12/31/24, and the annual out-of-pocket will be capped at 2,100 starting in this year. Okay, any other questions on Medicare before we go into Medicaid?
Yes, I have a question here talking about like Advantage plans versus the supplemental plans. So this question is that they've heard that Advantage plans do not act as a supplement in covering the 20% Medicare does not cover for dialysis patients. Is that accurate? And should we be encouraging our patients to get supplements plans as opposed to Advantage plans?
That is a good question. I don't know specifically about the dialysis. Maybe Jennifer, if you know, I think it's gonna,
Yeah.
yeah, go ahead
So
and speak on that.
Medicare, whether it's an Advantage plan or just the straight Medicare, the red, white, and blue card, will only cover at at 80%. So Advantage plans do not cover that 20%. Where supplement plans are recommended. However, sometimes it's harder for patients to get supplement plans, and they could be rather expensive.
And they seem to be getting more and more expensive. So I think, I mean, every Advantage plan is going to be different, is my guess. So you want to just make sure that everything is going to be covered with the dialysis. But then it kind of makes it so that people end up having to need Medicaid to cover that other 20%.
Yeah.
Which is unfortunate because it's, obviously like a major, I mean, we have a lot of people with kidney issues, and we want to keep them healthy. And when they don't go to dialysis, they get much sicker or worse. So, but
And
yeah,
then
yeah, go
Yeah.
ahead.
One other question I have on here, and I don't know if you can address this, but can you speak to anything around the behavioral health benefits under an Advantage plan?
Well, they should be covering at least um, what Medicare covers. But I would say with behavioral health, again, every policy is going to be, it seems like it's going to be different, and making sure that, that you're covered in your network. What I have found though is that most of these behavioral health, like counselors and psychologists, tend to be out of network on everything, whether it's private insurance or not. They just don't want to deal with it. But I'll check on that too.
This behavioral health.
Yeah.
Um, facilities, and I think
Oh,
they cover
I
the
see.
same as a nursing home type thing.
Okay, so what Michelle's saying is that it covers the facility same as they would any other facility, but I'm thinking, and I'm talking about more
But privately, it probably, I don't know what the coverage looks like.
and you would definitely have to find out which Advantage plan covers which,
Yeah,
which behavioral health center. So, yeah, it's just, I mean, it's like, don't get sick, right? It's just, there's so much like, I mean, once you get into the system, it's like, wait, what does this cover and this cover and that cover? But before going to an Advantage plan, I would say it may be better to be on regular Medicare if you have a major issue. Just in general, if I had like a major health issue and I needed to go to a nursing home, regular Medicare would probably provide me with more options instead of like the
Straight
HMO or the
Medicare, yes,
PPO.
yes.
Yeah.
so
So,
healthcare or behavioral health, like community mental health would probably cover, your Medicare would cover that. If you went to a community mental health facility. But again, I don't know what the copay would be. We could certainly look into that.
yeah. So yeah, it gets definitely pretty confusing. All
There was
right.
one other question that I just want to mention, and it was just asking about mental health med changes through Part D. And I think that's where, people are going to have to go through and, I tell social workers and patients all the time, talk with the broker, talk with somebody who knows what they're doing with the Medicare Advantage plans, run, Part D plans, and check all of your medications versus each plan to see what's going to have, better coverage for your medication.
Well, and I think it's always a good idea, even when you're on just regular insurance, to check those things before somebody puts you on some designer drug that is brand new and it's not going to be covered or whatever. It's just important, I think, to double check all of those things before you like switch medications. I mean, it's unfortunate we have to look at what the medication is going to cost under the new, whatever new medication is going to cost under your insurance. But it's the same thing with these formularies, and especially when you have 40 different Medicare drug plans, you've got to check the formulary before you, go into a new drug or whatever. For sure, it's just very it's a big system. All right, so we'll kind of like cover Medicaid in a pretty quick way to go here, but Medicaid, you got 4 main rules. I mainly deal with Medicaid in the community or in the nursing home, the aging Medicaid, but know that there's a number of different types of Medicaid. So what I'm talking about is elder law stuff. But so you've got to be below $2,000 in assets for the Medicaid recipients, and then the protections for the community spouse, I'll get into those. You've got to have no more than, your income has to be below 2901 in order to qualify categorically for Medicaid. And then anything above that has to go into what's called a qualified income trust. And then there's a penalty for transferring any assets within the 5-year look back. So they take from the date you make the application, look back 5 years. If you've given away anything, then they penalize the individual for 1 month, like 1 month where Medicaid will not pay the services for every 7,877 transferred. And then there's the estate recovery, which allows the state to come back over any assets that are in the name of the individual that was on Medicaid. And that's for anybody over 55, whether in a nursing home or in just regular community Medicaid. So exempt assets are your home, your household belongings, a wedding ring, 1 car, unavailable assets. I don't even know if they've ever found that. Cash value of life insurance if it's less than $1,500. Business property doesn't happen very much, but it is there. Up to $6,000 in rental income. If it's essential, burial plots, irrevocable funeral contracts, and retirement plans. All retirement plans actually are exempt as long as they're kicking out some income every month. Let's see. Countable assets are everything else. The community spouse can keep 1/2 of the couple's assets up to $157,920. And then if it's less than the half is less than, let's say 60,000, then you get to keep the $31,584. They make up these numbers, and then as soon as I get them down in my head, they switch it for next year. So the other half is supposed to, as default, go to the nursing home. And so it gets a little bit complicated, but you don't have to be completely broke in the nursing home to get on Medicaid. So if you have a spouse that's really, that's in dialysis in a nursing home, the spouse in the community is not going to lose everything. So these are some lawyery things, but countable assets, people don't know that the revocable living trusts are available. Life insurance, cash value, annuities, money held with children, still countable. Life estates doesn't happen too much anymore, but and then that real estate one doesn't apply. Again, income, I'm going to go so the income is supposed to all go to the nursing home, but if there's a community spouse, that spouse gets to keep all of their assets. And then if they don't have as much in assets, if they have below 2644, they will at least get that much of their spouse in the nursing home's income to get her up to 2644. And if there's household expenses, then you can get up to 3948 per month. So that's again, people go, I'm not going to do the nursing home because I'm afraid I'm going to lose everything. Well, we're not going to lose everything. We have lots of protections here. Transfer of assets, again, it's 7787. Basically, so again, if you transferred 77,000, it causes 10 months of ineligibility for Medicaid. You can have some exemptions, which would be the caretaker child, that's a child that's lived in the house for 2 years and provided care that kept them from going to the nursing home. A disabled child, and this could be an adult child, if that disabled child is it could be disabled under Social Security or disabled under, like an OPERS or something like that. yes, that a child under 21, oddly enough, I have a few clients where they have a child under 21. Um, so we've been able to transfer to that to them. That carries its own risks, but so that's kind of a problem. Um, and then the start date for these penalty periods are when the person is otherwise eligible. So what that means is if it's a single person, they've got to be below 2,000 and it's got to be under the community spouse resource allowance so that whatever their half split between the couples or 157,000, then the penalty period can start. So if we have that 10-month penalty period, that's when it starts. So it used to be that it would start and then it would be done before you ever went into the nursing home, but that's not the case anymore. So you've got to like go to Medicaid, tell them what you did, and then go back to Medicaid after the 10 months and get on there, get on Medicaid. And then in the meantime, you have to be able to pay for the cost of care during that 10-month time. So you've got to either move money into a pooled trust or an annuity or something so that we can make sure that they'll have enough money to pay for that 10-month period and not have them getting kicked out of the nursing home.
Now, Rachel, I have a question. So if a patient is already on Medicaid, so for example, a lot of the dialysis patients are eligible for the specialized recovery program because of their chronic illness. So they're able to get on Medicaid with a little bit of a higher income. So with that being said, if they're already on Medicaid and they end up in like a long-term care facility, is that do those rules still apply as far as um kind of the money that the nursing home, the penalties that they get if they kind of sell things or uh leave things to family members, that penalty, does that where they get off of Medicaid at that point, or do they remain on Medicaid?
So my thinking would be like every program within Medicaid is going to be slightly different. So one penalty, like Magi Medicaid, for instance, the modified adjusted gross income Medicaid, that doesn't have a penalty period for gifting. So as long as the person stays healthy for 5 years, you're good. So it's possible that with the program you're talking about, you may not have, like, they're not asking about that. But if they need to convert over to a Medicaid in a nursing home or assisted living, then we do have to answer for those things with Medicaid. So, and anytime you make a transfer, let's say you were on Medicaid and then you got money, I don't know, like maybe you inherited something, you have to then tell Medicaid about it. So we'd have to look at each program and make sure that we know, like, well, what are those rules? But if that's a rule just for like getting dialysis care and transportation and all those, individual programs, it's possible that that doesn't have any penalty period looking back or, anything like that. But if they do go to the nursing home, we're going to probably have to address it. Yeah, so, this is mainly like I tell lawyers particularly, like, are they going to need long-term care? Because clients all the time are like, well, I'm going to just move everything. And I'm like, well, are you sure that's a good idea? Like, I love when clients call me and they're like, I need a trust. I'm like, well, how do you know you need a trust? Like, maybe that we need to figure out whether you need a trust at all. But, do they have a disabled or dependent child? Are they being well cared for? Do they need more help? What's the help going to cost? So those are the things that we always kind of calculate into it and figure that out. So spend down is always okay. People think, oh my God, I bought myself a car, like I'm not going to be able to get Medicaid. No, Medicaid does not care about that. They just care if you bought your son a car or somebody else a car. But you can pay for dental care and private room, prepay assisted living facility for a wife, pooled trusts, which are it's basically a special needs trust for over 65, and it allows that nonprofit to pool the assets of multiple different uh, individuals into it, and then they will pay for the cost of care during that 10 months, or they'll pay for any of these other things, so that we can qualify and get them Medicaid. And then, yeah, there's so many tools for planning. I don't want to get too much into this, but we can gift. We can always gift even on the doorsteps of the nursing home. Why are we gifting? Well, we want to make sure that there's extra funds for that person's needs. And so that's the main goal behind that. I'm not really looking to protect the kids and things like that, but I do want to make sure that, people oftentimes, especially with dementias, they need somebody to sit with them and like make sure that they're okay in their facility. And if there's no money for that, Medicaid's not going to cover it. So, so again, estate recovery, the state has the right to seek recovery for benefits it previously paid from the probate and non-probate estate of the deceased Medicaid recipient. So life estates, they don't do so much anymore, but any joint accounts, transfer on death, deeds, anything like that, we definitely have, they will go after it. So it's, they've gone after just a little piddly account at the nursing home. So it's really important to, like, at least even once we get them on Medicaid, that we make sure that we've protected the spouse by taking their name, to save the Medicaid recipient off the house. So lots of different things that go into this. So our main thing is to look at, as an elder law firm, like the legal, the care, and the financial, and come up with a tailored plan for these individuals so that they can make sure that they are not left holding the bag of a very big bill at any nursing home or that kind of thing, and that they at the same time get good quality care, in whatever facility they're in. So, whoo! All right. So I think I'm gonna just leave it there. Oh yeah, I don't know why 70, like those. Oh, I had some hidden things.
I have a couple questions that came in. So if a patient is in a nursing facility under Medicaid, with the spouse remaining in the home, after that patient dies, does the Medicaid come and automatically take that house from the spouse that's still living in it, or what are the rules with that?
So they cannot execute on their Medicaid estate recovery until the spouse has passed. So and the spouse that's in the home. So the spouse in the nursing home dies, the house is in both names, then they will wait until the spouse in the home dies. Now we can protect that house by making sure that the house is not in the name of the Medicaid person, the person in the nursing home. We can move it to the wife's name in the community or the whatever healthy spouse, and then we can prevent that from being uh, included in the Medicaid estate recovery. So it's a simple quit claim deed, and it can protect a half of the house, with no problem. If not, if the wife like lives in the home and then she decides to sell it and buy another home, then Medicaid estate recovery only had an interest in that home that he had when he was alive, when he died. So it gets a little complicated, but people think like, oh my God, I can't give anything to my wife. Well, yeah, you can, because there's no improper transfer between spouses. But that's a great question too.
And then one other question in regards to that, does that count if the patient's spouse remarries? So if they remarry, is that how, I mean, is there anything that is protecting that house from that?
So if the spouse remarries, I would just recommend that they go and buy a new house for their new with their new marriage, so that they don't have any, asset where the state would be claiming anything on that old house because it's already been sold and they bought a new house. So that's probably the easiest answer to that. And then yeah, that's how we can do it. I have another client where we had to do where a kid has to buy the house, the half of the house from the mom, so that we can get it out of the dad's name, and then we can, basically tell Medicaid to pound salt. So, I mean, I think it's one of the most unfair things that you go through all of this Medicaid eligibility, and then you, at the end of all of that, then you also have to give them more money back. Like it's just, but we can prevent it almost always by making sure that there's very little money in the name of the spouse in the nursing home. Any other questions?
I am looking. I guess one of the questions here, it says, her question was, did she understand that the assets that are transferred to a child before that lockout period, does that still account against the person applying for Medicaid? So I assume that's within that 5 years.
So if it was outside of before the look back period, so if it was transferred to the child before the 5 years, then it does not count into that. So that would not be, let's just say that the person on nursing home in the nursing home had $100,000, they moved it all to the child, and there's only $2,000 left now, then they won't count that 200,000 or the $100,000 that you transfer. And then I see our spend downs done one time or on a monthly basis to keep Medicaid. Well, so yes, both. I would say that you do some spend down, just to get to that $2,000. And then you shouldn't need to necessarily in a nursing home do it on a monthly basis to keep Medicaid. But back in the day, right, you would have the monthly before the qualified income trust, and you'd have the $2,901, and you qualify. But before it used to be, well, you better spend down 2,901, and then you could okay, wait. So sorry, there's like popping up too. So it's like, oh my God. Okay. So what I would just say is that you before you spend down whatever your income was and you'd qualify for Medicaid that month and then the next month and then maybe you didn't spend down that month and so you didn't qualify for Medicaid. So now it's simpler, where you have to be 2,901, but when you're in a nursing home, all of your income is still, except for spousal amounts, still go to the nursing home. And then what if it's spouse who's part owner of the house? No. So girlfriends don't count. Sorry. Like, got to get married. But then maybe you shouldn't get married. Like I've been telling my dad, don't get married. You're 86 years old. Like it's not a good idea. Unless you really want to pay for somebody's long-term care. So no, it's got to be now. If it's a co-owner, there may be ways for us to work around that, but that's more like Medicaid 201. And then I have a Medicaid about Medicaid spend downs is a, oh, 9 months. Okay, so we covered that. And this is done to ensure patient can keep Medicaid. Is my understanding of that correct? Yes, you've got to be below $2,000. So if things start to move up, then we have to definitely kind of take a look at uh like what's going wrong that they keep accumulating assets. Um, if they okay, if the person's in the nursing home, and then I think this will be our last question, can they transfer the deed to another family member so you will not have problems? That's got problems when you move. If you're doing it within the 5-year look back and you transfer that house, they're going to divide the value of that house by 7787 and give us a number of months that they would be ineligible for Medicaid. So we don't want to do that. Anytime you're doing transfers, it really needs to have like some type of certified elder law attorney take a look at it. So,
Right.
all right.
Well,
Thank you, Jennifer, for having me. That was like, you guys are tougher than my law school class.
well, we appreciate all this information. Thank you.